negativity. So this is a right bundle branch block because my L1 has got delayed slurred terminal negativity. That means terminal vector is going away from my L1. L1 is a horizontal and left sided lead. Because it is going away, terminal vector is going towards the right side. It has to be a right bundle branch block, isn't it? So this is a slurred S wave. If you have the slurred S wave in L1, it is the right bundle branch block. Slurred S wave in L1. Whereas you look at this ECG. Here you see that V5, V6, you look at the L1. You look at this exactly the similar QRS complexes in V6 and L1. Almost similar. So here is QRS widening. Terminal component is what? Positive or negative here? Positive. So what bundle branch block this is? Left bundle branch block. So just like looking at L1, it is possible to say whether it is a right bundle branch block or left bundle branch block. Because L1 is going to mimic V5, V6. Left sided leads will tell you whether the terminal vector is coming towards left or going towards right. So V5, V6 is going to tell you what vector it is going. So it is looking at L1 itself, we are going to say whether it is a left bundle branch block or a right bundle branch block. So this is left bundle branch block criteria. So now look at the ECG. What bundle branch block this is? Right? RBB or LBB? Or why RBB? Slurred negativity. What is it? Chest leads. What is it? RBB. So you are confirming with a looking at L1. So looking at L1 here, you think it's an RBB. In chest leads, it is right bundle branch block. So it's a classical right bundle branch block. So what is it? So we can say L1, terminal delayed slurred, positivity is there. So this is, you can see in this chest leads, it is left bundle branch block. V1 is negative, V5, V6 terminal delayed positivity. So L1 itself will give you a clue whether it is a right bundle branch block or a left bundle branch block. So just look at L1. So as it is being recorded, without looking at the chest leads, if you say it is a bundle branch block of right or left, people are definitely, you think you say ECG pista and so on. So you'll have a definite approach to you whenever they see you, they see you a lot of admiration and lot of. So it also can be a complete right bundle branch block or an incomplete right bundle branch block, depends upon the QRS widening. If the QRS is just widened, just 3 squares, it is called incomplete bundle branch block. The QRS is widened more than 3 squares, it is complete bundle branch block. So incomplete or complete depends upon the QRS width and duration. So this is your summary of bundle branch block. So in bundle branch block, first thing is QRS widening more than 0.08 second. Once it is widened, look whether it is due to the initial delay or a terminal delay. If it is initial delay, it is WPW or a pre-excitation syndrome. If it is a terminal delay, it is bundle branch block. Once you decide it is a terminal delay and bundle branch block, thing to be seen is a terminal delayed slurred positivity in which group of leads. If the terminal delayed slurred positivity is over the right sided leads, it is right bundle branch block. 5% of normal people can have it. The concept is the right ventricle is the last one to be activated and it is activated through the muscle. Last vector is coming towards the right side. Whereas the terminal delayed slurred positivity is over the left sided leads, it is left bundle branch block. The concept is the left ventricle is to be activated late. This activation front is coming from the right ventricle through the muscle. So the left sided lead will have a terminal delayed slurred positivity, almost always pathological. Left bundle branch block is almost always pathological. Of course, looking the QRS width of more than 0.08 but less than 0.12, it can be an incomplete bundle branch block. More than 0.12, it can be a complete bundle branch block. Whereas looking at L1 itself, it is easy to understand and diagnose a bundle branch block. L1 shows the terminal delayed slurred negativity, it is right bundle branch block. L1 shows terminal delayed slurred positivity, it is the left bundle branch block. So this is looking at the L1 itself, you can diagnose a bundle branch block. So the QRS widening can happen due to so many other situations also. It's not only bundle branch block, not only WPW syndrome. It can happen, as I told you, many drugs can induce a left bundle branch block or a QRS widening. So the drugs which can produce an abnormality of the action potential of the initial upstroke, the sodium entry. Because as I told you, action potential, the upstroke corresponds to your QRS. So whatever the abnormalities which is happening in the upstroke of sodium entry can widen the QRS. Even though you do not have a bundle branch block, because of the abnormal entry of sodium which can happen, which can widen your QRS complex. The important drugs which can widen QRS complex are tricyclic antidepressants. The tricyclic antidepressants, especially the toxicity of tricyclic antidepressants, most often suspected by looking at the QRS widening. Due to ECG in QRS widening, if the QRS gets prolonged, you know there is a significant tricyclic antidepressant toxicity. Right? Ready? Bundle branch block produces initial delay, terminal delay, neither. For this question, 189 people are answering. Neither 2%. Right bundle branch block, septal activation is altered. True, false? No, one person, I think. So I have to give a question. You are in IIT campus, yes, no? I know that, or at least that question, whether will I get 100%. I am in IIT campus now, yes, no? Can't say. RBB terminal vector travels towards left. True, false? RBB terminal vector travels to left. Terminal vector. Yes. See, almost 19% true. See, terminal vector, see RBB, the terminal vector is coming towards your right side. Right ventricle is the last one to be activated in right bundle branch block. So, terminal vector in right bundle branch block should come towards the right. That's why the right side leads will have a terminal delayed slurred positivity. So, it cannot go towards left. So, the answer is false is the right one, but 1/5 still have some confusion, I hope. So, right bundle branch block, terminal vector travels towards right. In left bundle branch block, terminal vector travels towards the left. So, please understand that concept. Left bundle branch block, mass interval infarction. True, false? True, because in left bundle branch block the septal activation is altered, because majority of your infarctions is going to affect the initial portion of QRS. For example, you have a pathological Q wave. It is the initial portion of QRS which is going to be altered in myocardial infarction. Here, the septal activation itself, the initial portion itself is altered. That's why it is difficult to diagnose central infarction, because it is going to alter the depolarization process which is going to be affected by the myocardial process. So that's why it is difficult. Initial septal vector in LBB. Initial septal vector in LBB. Right to left, left to right, no idea. Good. In a left bundle branch block, because the left bundle is not there, the septum is activated from the right bundle from right to left. That's why you will not have the septal Q wave in left bundle branch block, right to left. This ECG, which bundle branch block? Right, left? Yes. Right to left confusion. So you can see that first QRS is widened. It is widened. Then see the terminal delayed slurred positivity. The right side leads has got the negativity and the terminal complex. So it cannot be a right bundle branch block. The terminal vector is coming towards left and it is slurred. So terminal delayed slurred positivity or left side leads. The classical secondary STT changes there. So it's a classical left bundle branch block. Which bundle branch block? Yes. Naturally, when I show first slide as left bundle branch block, the second slide has to be right bundle branch. So you need not diagnose that. It has to be right bundle branch block. So where is the terminal delayed slurred positivity? It's over the right sided lead. So what is abnormal here? Is there anything else abnormal? What is the axis? So that's what I told you. Right bundle branch block, I will not look at any other thing. Only bundle branch block. I will not look this side, limb leads I will not look. So when you look at that ECG, so many things now you know. Try to calculate the rate, try to see whether P waves are abnormal, try to calculate the axis. What is axis? Normal axis. Normal axis means either L1, L2 or AVF should show the tallest positive QRS complex. Is there a tallest positive QRS complex? Left axis. Yes? Indeterminate axis. So all your complexes are equiphasic. See the terminal R wave in AVR. Whenever there is a terminal R wave in AVR, all your complexes are indeterminate. Is there anything else abnormal here? Is it a classical right bundle branch block or not classical right bundle branch block? Yes, yes. Yes, louder. What's happening in V1, T wave? What happens to normally the RBB T wave in V1? You must have secondary STT change. What is the T wave there? Normal. Why it is normal? So this is what you must see. That is the advanced ECG learning. when things, classical things are not there. So diseases don't read textbooks. Diseases do not go and read Leo Shamrath ECG book and come and present exactly the Leo Shamrath as described right bundle branch block in your patients and your ECGs. There will be so much of variations. There will be so much of differences in patient to patient. So here you have the absence of secondary STT change. You do not have the secondary STT change in spite of right bundle branch block, where you expect the ST segment, the T wave to be negative. Here the T wave is positive, which is called homophasic STT change. So in the presence of a bundle branch block, if your T wave is happening in the same direction as a QRS, which is called homophasic STT changes, you must suspect associated CAD, coronary artery disease. What happens in coronary artery disease? Normal T wave gets inverted, isn't it? In a coronary artery disease, normal T wave gets inverted, you say ischemia. When already the T wave is inverted, ischemia produces the normal T wave. It produces, already the T wave is inverted in bundle branch block. When ischemia supervenes, it produces the opposite direction of the pre-existing T wave. So already T wave inverted become normal. So whenever there is a right bundle branch block, if your T wave change is not there, secondary STT changes are not there, you must suspect associated coronary artery disease. Subtle sign of coronary. Although other changes are not there, classical ST depression is there, classical ST elevation is there, everybody will diagnose CAD. But you must diagnose CAD when all the other people are missing CAD. See, that's what you must always see. That's what the ECG learning, we always say, obvious is obvious. Look for inobvious. Here the right bundle branch block is obvious. Everybody will diagnose right bundle branch block. But because the absence of secondary STT changes, you are supposed to suspect an associated coronary artery disease, which may be contributing to the right bundle branch block development. So this is a homophasic STT change. So you must say that, sir, you must ask me, sir, where is the STT change? What I tell you, you agree. Whatever I say, it's right bundle branch block, you agree. So don't agree with me. So disagree with me. So you must also suspect a coronary artery disease here, right? It's a right bundle branch block. I am showing you only L1. I have not shown you the chest leads. Which bundle branch block? Look at the L1. Yes, start. Yes, good. See that L1, the initial portion is normal. There is a terminal slurred negativity is there, terminal SS there in L1. So it is the right bundle branch block. So it is a classical right bundle branch block. So any doubts in bundle branch block or any doubts in any of the topics I told you? Anything you want to redo again? Anything so you can rapidly redo it again? Anything you want to redo again? Anything you are not understood or any chapter? Otherwise, we will go for a very brief topic. One more brief topic is there in QRS widening. Any other things you want to do it again? Anything? You are absolutely clear. Absolutely clear or unclear? Yes? Yes, madam? You want to know the activation and LBB, that diagram. You want to know the activation sequence of LBB. Again. Yes. So in a left bundle branch block, your left bundle is blocked here. So normally the septal gets activated from left to right by the left bundle branch block, by the left bundle. Because the left bundle branch block is there, now the right ventricle is going to activate the septum from right to left. Is that clear? So normally it should happen like this. That's why you have an initial R wave in V1, initial Q wave in V5, V6 due to septal depolarization, which is going away from your left sided leads. Whereas here, because this is blocked, this septum has to be activated first. Now the right bundle activates the septum. Once the right bundle activates, it goes from here to here, from the right to left. So because of that, you don't have the septal Q wave in V5, V6 there. So that's why the septal activation is altered in left bundle branch block. In left bundle branch block, there will not be initial septal Q because the first vector itself is going to come towards the left side. Now, there is a small right ventricular activation which will happen, which may produce a small slur. Because the right ventricular activation is so weak, it may not produce a significant. Normally, it's produce an R wave here and it's produce a S wave here. Because this right ventricular activation is coming towards the right side, which will produce an R wave in V1 and S wave in V5, V6. So, because the right ventricular activation is so weak, it may produce just a slur or a small positive component in the downslope of the QRS complex in V1 there. So, this is a normal right ventricular depolarization. Then, by this time, normally the left ventricle also gets depolarized if the left ventricle is intact. Now, because the left ventricle is still not depolarized at this point in time, because the right ventricle is depolarized, left ventricle is not depolarized because the left bundle is blocked, for which the conduction system has not carried the impulse there. So, the left ventricle is depolarized by the impulses which are traveling from the right ventricle towards the left ventricle through the muscle. So, because of this, this terminal vector is directed towards the left ventricle and it is traveling through the muscle, resulting in a terminal delayed slurred positivity over the left sided leads and terminal delayed slurred negativity over the right sided leads. So, that is what I told you. The concept to understand in a bundle branch block is whichever the ventricle for which the bundle is blocked, it is going to be activated last. For that, the impulse has to come through the muscle. Non-specialized conduction system traveling at the speed of 400 millimeters per second rather than 4000 millimeters per second. So, naturally, this last vector is going to be delayed and slurred because it is coming very slowly. So, that ipsilateral ventricle for the bundle is blocked is going to be activated last and it is going to be activated in a delayed manner, which results in a terminal, delayed. All the three words are important. It is terminal, it is delayed, it is slurred. Positivity over the right sided leads is right bundle branch block, over the left side is left bundle branch block. Because that particular ventricle, the depolarization is delayed, repolarization starts in the endocardium to epicardium. So, you have a secondary STT change, downsloping asymmetrical T wave change happening in the presence of bundle branch block. The absence of secondary STT change in the presence of bundle branch block is called homophasic STT change. I want you to suspect associated coronary heart disease. That clear? Right. We will briefly look at the other important cause of QRS widening. What is the other important cause of QRS widening? Yes? So, before we go, we will pre-excite you, right, so that you go with some excitement. So, this is a pre-excitation syndromes. So, here what happens is in addition to normal conduction system, we have certain additional fibers which connect the atrium to the ventricle. So, these are called accessory pathways. So, are called accessory pathways. This can happen as a congenital abnormality or it can happen associated with the congenital heart disease. Certain congenital heart disease may be associated with the accessory pathways. So, there are three known accessory pathways. One is an accessory pathway which connects the atrium to the ventricle. From the atrium to the ventricle bypassing the AV node. So, this is the commonest of the bypass pathways or accessory pathways, which is called Kent pathway. The Kent pathway connects atrium to the ventricle. Then there is a pathway which can connect the atrium to the bundle of His. It can connect the atrium to the bundle of His bypassing the AV node, but it connects the atrium to the bundle of His. This is called James. And third pathway is the one which is going to connect the atrioventricular node to the ventricle, from the node to the ventricle, or vesicle from after the node from the vesicle for the bundle of His to the ventricle. Instead of normal conduction system, there is another pathway which can connect from the His bundle to the ventricle, which is called Meheim. So, these are the three important pathways: Kent pathway, James pathway and Meheim pathway. Atrioventricular, atriohisian, hisian ventricular, or vesicular ventricular or hisian ventricular are the three pathways. So, it is very easy to diagnose what pathway by looking at the ECG. From ECG itself, you know which pathway you are dealing with, right? Here, for example, you see that very importantly, because my AV node is bypassed, what will happen to my PR interval? PR interval will be short. So once this is bypassed, subsequently this vesicle or this accessory bundle connect to the muscle here. So no longer it is connected to the specialized conduction system. Although the impulse coming rapidly to the ventricle, subsequently it is going to conduct through the muscle. So the initial impulse comes rapidly to the ventricle, then it conducts very slowly. That's why you have a slur initially, which is called delta wave. So whenever I have a short PR interval and initial slur in my QRS, I know it is atrioventricular accessory pathway, which I call them as WPW syndrome. So here what happens is, I have a short PR because my AV node is bypassed. Subsequently, my conduction is through the muscle, which will produce the initial widening of QRS. This is what the ECGs I told you. Short PR, initial slur, which is called delta wave, terminal sharp QRS complex. So whenever my PR interval is short and there is a delta wave, I know it is a Kent pathway. It is a WPW syndrome, Wolff-Parkinson-White syndrome, when it is associated with tachycardia. The syndrome you call it when there is an episode of tachycardia. When you look at the ECG alone, patient does not have any episode of supraventricular tachycardia. You call them as accessory pathway, not WPW syndrome. WPW syndrome is given once you have demonstrated episode of tachycardia. Right, now look at here. Here my AV node is bypassed. After that my conduction is normal. Isn't it? My pathway is bypassing the AV node, then connect me to the bundle of his. Subsequently my conduction is going to go through the specialized conduction system. So no longer here I will have a white QRS, isn't it? No longer I have a white QRS because my accessory bundle is not connecting to the muscle, it is connecting to the specialized conduction system. So here the AV node is alone bypassed, I will have a short PR but normal QRS complex. So I have only normal QRS complex is normal. There is no initial slur, there is no terminal slur, QRS duration is not 8 seconds, my PR interval alone short. So that means I know AV node is alone bypassed. So this is a James bundle. Whereas here, my AV node is not bypassed. Isn't it? Up to this time, the impulse is coming through the AV node. That means what is happening in my PR interval? Normal. After that, one portion is getting excited through the muscle by the accessory pathway, means this will produce an initial delta wave because after this, a portion of ventricular muscle is activated by this muscle by non-specialized conduction system. So I will have a delta wave. So if I have a short PR and delta, it is Kent. If I have a short PR, normal QRS, it is James. If you have a normal PR with the delta, it is Meheim. You understand these points? So it is all depends upon where your accessory bundle is getting conducted. So it is totally bypassing the AV node and initial activation itself is through the muscle. You will have a short PR and delta. It is Kent. After, if James, the AV node is bypassed, there is no abnormal ventricular depolarization through the muscle. So QRS is normal. PR short, QRS normal, James. In Meheim, which is very rare, the PR interval is not shortened because your accessory bundle starts after the AV node. Then it connects to the muscle. But you will have a delta wave because this bundle is connecting to the muscle and activating the myocardium. Aberrantly, you will have the initial slur. So from ECG itself, if you understand this concept, looking at the ECG, you know there is an accessory pathway. You know what accessory pathway this is. Is that clear? So these are the three important accessory pathways you can easily diagnose by looking at the ECG. So you can see this accessory pathway. The problem is there is an accessory pathway here. So what complex, for example, I am now going to concentrate only on the Kent bundle. The Kent bundle is the one which is connecting the atrium to the ventricle here. Normal AV node is here. So what happens is my normal impulse, which is coming from the sinus node, one portion will go through the normal conduction system, which will get delayed through the AV node, and it will, as it going through, one portion will be going through the accessory bundle and reach the myocardium very early. So your QRS complex, because this portion of the myocardium, because this portion of the depolarization process is reaching the ventricle very fast, your PR interval is short. After this, once it is come to the ventricle, it is getting conducted very slowly because it is going to go through the muscle. That initial portion tells you the activation front which is coming through the accessory bundle. By the time it is slowly spreading, the impulse which is conducted through the normal system after getting delayed at the AV node gets rapidly conducted through the specialized conduction system that produce the initial sharp portion or the initial normal portion of QRS which is coming through the normal conduction system. So actually the WPW syndrome ECG complex is fusion complex of depolarization fronts coming through the accessory pathway and through the normal pathway. The initial portion of the QRS complex is rapidly reaching the ventricle but then getting conducted slowly. That's why your PR interval is short, you will have initial delta wave. By the time it is spreading slowly here, the normal impulse after getting delayed at the AV node gets rapidly conducted through the special conduction system that produces the terminal sharp portion of the QRS complex. That is the difference between your bundle branch block and pre-excitation. In pre-excitation, the abnormal depolarization is happening initially, whereas in a bundle branch block, the abnormal depolarization happening at the last. That's why you have a terminal delay there, you have an initial delay there. So looking at the QRS itself, we know whether the activation fronts through the abnormal pathway is larger or through the normal pathway is larger, right? If I have a very short PR and a very large delta wave, my majority of impulse is coming through my accessory pathway. Whereas my PR interval is just short, I have a small delta wave. That means majority of my wave is coming through the normal pathway and small amount is coming through the accessory pathway. So this is actually the ERS complex you are looking at in WPW syndrome or the Kent pathway of short PR, initial delta, terminal narrow QRS is the fusion complex of two activation fronts which is coming through the accessory pathway and through the normal pathway. Is that clear? So this is how we derive the ECG and look at the ECG not only to diagnose it's a Kent bundle but also to say whether the, for example, 100% activation front is coming from the sinus node, whether it is 75% through the accessory pathway and 25% through the normal pathway, or 75% through the normal pathway and 25% through the, I'm now looking at the short PR interval and the delta wave. Shorter the PR interval, larger the delta wave, 70% is going through the accessory pathway. Near normal PR interval, the small delta wave, 70% is going through the normal pathway. So this is what you can decide. What is the importance? Why we have to break our heads at 7:30 PM today on Saturday about WPW syndrome? Right? Is because of its ability to produce a supraventricular and dangerous arrhythmias, which is life-threatening arrhythmias. So this is a fusion complex, as you can see that the activation fronts coming through the accessory pathway and also the actin pathway produces the short